Hello, I'm Dr. Abdülkadir Göksel from Istanbul, Turkey. Today we are going to perform close approach preservation rhinoplasty on this beautiful 40 years old lady. So I want to explain my plan and I want to share with you the details of the plan and why we are doing close approach. During the surgery, actually you will see all the details, but when we see the patient first time, we have to concentrate the direction of the nose. As you can see here, when you draw the midline through the midline of the eyebrow, midline of the eyes, and the midline of the lips, in soft tissue midline, we can recognize that the nose goes to the left, so it's a crooked nose correction. In daylight or room light, it's not such significant, but when you take the photograph with paraflash, which you can understand the flashlights on the eyes, you can see the dorsal aesthetic lines that they are not straight. When the patient smiles, you can see the details on the tip of the nose, if there is any droopy tip, plunging tip, or the alas are moving up, or the crookedness is getting more visible or not. That's why the dynamic photograph is also another important issue. And when you check the patient from three-quarter view, you can focus to the radix height. It's over-projected for this case because we cannot see any deepness here. It can be the procerus muscle, it can be the soft over-projected radix, and we can see the hump, if it's soft or kyphotic, because it depends on the shape of the nasal bones. The hump can be kyphotic or straight. We have two different kind of nasal bones, actually, V-shape or S-shape, and this patient has very good V-shaped nasal bones. We don't need to rasp the dorsum, as we can see. And from the other portion, we can see the hump from left three-quarter view. Sometimes it is very different from the one side to another, so it shows us the asymmetry on the dorsal aesthetic lines. If the dorsal aesthetic lines are really asymmetrical, we see totally different three-quarter views. So it means that patient's dorsal aesthetic lines, as you can see here, straight, but the nose is tilted to the left side. These are the best candidates for preservation rhinoplasty. And most of the patients, if they have this kind of asymmetric nose, but parallel dorsal aesthetic lines, the Kotel maneuver, low septal strip, works better than the other techniques. And sometimes we have the slight deviations, so subdorsal flap or high septal strip can also work nicely. But for this case, especially from the base, we can see the deformity of the caudal portion of the septum. It tilts to the left side, so it is much better to tilt all the septum to the midline. It means that the Kotel maneuver, low septal strip, is a good option for treating this deformity. And from the side, we can judge the nose, we can judge the radix. As you can see, the nose goes directly straight to the eyebrow line, and we cannot see the deepness on the radix. That's why I want to reduce the height of the radix, so we will deproject the radix. And the hump is very slight, it's not kyphotic hump, so it is very good candidate for flattening the dorsum. We will use some stretching maneuvers, and I will talk about the blocking points. We have to kill all these blocking points, and I will add ballerina maneuver. It will be a lateral keystone disarticulation. And we have a simulation. I want to share with you the simulation also. This is the flash photograph. It shows us the details on the base because we cannot see these details with the paraflash photographs. When we take the photograph with single flash, which you can understand on the eyes that it's a single flash photograph, we lose the details on the surface. We concentrate the details on the base, then we can see a little bit large frontal process of the maxilla on the right side, and the left side is smoother. So let's focus to the simulation. So this is just the overlapping photograph with the simulation and the patient's own nose. We can see the details that we don't need rotation on the nasolabial angle. We need a little bit less tensioning. As you can see, there is a small difference between before and after, and we don't need to change the projection on the tip of the nose, but we have a huge hump reduction with changing the shape of the convexity, and we need to reduce the height, so we need to deproject the radix. It makes feminine effect on this nose. And I do always 3 different angle simulation. This is the simulation again, three-quarter view, because patients know themselves, they can recognize their face better on the three-quarter view. Side view doesn't make a lot of sense for most of the patients, but three-quarter view is very important. This is the three-quarter view simulation. As you see, I lowered the radix height. I did this straight, flat dorsum for her. And another simulation I usually for the helicopter view, and I can change the dorsal aesthetic lines. So let's start. I will start with the injection. Now we will get ready for the surgery. Now we ask our anesthesiologist if the patient is stable or not, because when the patient sleeps, if you inject immediately adrenaline, you can make instability. So the blood pressure can be really high after adrenaline injection, and there can be tachycardia, there can be arrhythmia. That's why we have to collaborate with our anesthesiologists. They are a good friend of mine, and we are working with the best team here. So as you see, the carbon dioxide level is 25, 26. So it should be lower than 30 because the body gives the first reaction with carbon dioxide and tidal level. Now I can inject my local anesthetic. This solution is 0.5 milligram adrenaline inside 1 milliliter and 2% lidocaine and 14 milliliter saline solution. So totally 20 milliliter solution we prepare. I just inject 2 or 3 ml, not more, and very slowly injection. I have to be sure I'm in the correct plane. You can see the white color here. It means that I'm just on the supraperitoneal plane. So I just inject slowly and wait. As you can see the white color. And it takes 5-6 minutes to inject this local slowly. Then after that, I wait about 10 minutes more. When I see the very whitish color on the nose, comparing the cheeks, it should be really whitish. And I just check the color difference. When it's really white, I start my surgery. During that time, I scrub, I wash, then I don't waste time. So this will be close approach rhinoplasty. That's why I will inject first my incision lines. So the long incision I prefer when I'm doing close approach. I start to inject to the lateral crus from the apex of the nostril. Then I just follow the root of the nostril. Then I just inject slowly. So this injection helps on 2 layers, vestibular part and the skin part. And my incision line is already injected on the left side. On the other side, again the same trick. I start from the nostril apex. So I follow the root of the ala. Then I inject slowly. Then you can see this white color. It helps to the skin and the vestibular skin side again. As you see, just 1 ml we injected so far. After the injection of adrenaline, you can see the level of carbon dioxide level, and tidal carbon dioxide is still low, 25, so I can inject. If it's over 30, I just stop and wait. So this is the osteotomy tunnel injection. I start from the vestibular skin and I approach the medial canthal ligament area. Then I inject my local and come back, 0.5 ml. It creates the bump on the lateral bony compartment. As you can see, this is the lateral bony compartment. It cannot go higher because this level is the nasomaxillary suture line attachment between the frontal process of the maxilla and the nasal bones. So this is another compartment. If I want to inject, if I want to enter the dorsal compartment, I do additional injection on the dorsum. I will repeat exactly the same injection on the left side. So this is another side injection. I create the bump on the lateral bony compartment. So totally 3 ml injection I used for the dorsum. Now I will continue and add a little bit more to the radix, because on this case I'm planning to make reduction on the radix. If I don't need to do anything on the dorsum, I even don't need to dissect the dorsum. So I don't enter the dorsal compartment. So this is the local injection for the dorsum. I just inject the dorsal compartment, and this injection will not spread to the lateral side because there is a barrier between the dorsum and the lateral bony compartment. And there is also tip compartment which separated from the lateral bony compartment and dorsal compartment with scroll attachment here. So once you inject to the tip this way, it stays just on the tip. So we inject it to the all compartments on the surface. Now we are ready to inject to the septum. On the septum, I dilate the injection, my solution, with 50% saline solution. So I will get additional syringe from my nurse, septum locally. Now we will inject to the septum. As you remember on the photographs, our caudal portion of the septum was appearing on the left nostril, so it's not on the midline. So this is our caudal portion of the septum. I will inject my local solution slowly. If you're in the correct plane, you will see the white color. As you can see, slowly injection. We saw the white color. And I need to inject to the anterior nasal spine because most of our work will be on the anterior nasal spine. If there is no pathology on the base, if it's not crooked nose, if the septum is straight, we don't need to disarticulate the septum from the base. In that kind of cases, I usually do high septal strip. Works very well. But this case, we need to relocate the caudal portion of the septum to the midline. That's why I prefer low septal strip. Okay, now I will inject more on the left side. And the last to the scroll. Now we are ready. We have to wait a few minutes to see the whitish color on the nose. Now you can see the whitish color on the nose and the reddish color on the cheek. So there is a separation. It means that our vasoconstriction effect started. It's a good sign that you can start your operation. So this color difference is the most important sign for me to start my operation. So the plan is making this straight, flat dorsum, and the dissection plane is very important when you plan to make low septal strip. Basically, what we are going to do, we will separate the relationship between the ethmoid bone and the quadrangular cartilage, and we will split the quadrangular cartilage from the maxillary bone. So quadrangular cartilage will be free of tension bone around. It will be flat. And also we have to disarticulate the relation between the ethmoid bone and the dorsum. So this is a long disarticulation which we are going to do on the septum. Then we will resect the height from the base. So we will make the resection on the base. That's why we call it low septal strip. Then we will rotate the septal cartilage caudal direction. So we call it SPQR from Dr. Finocchi. It's kind of Cottle maneuver, but there is a rotation flap. And also I will disarticulate 3-4 millimeter the septal cartilage from the dorsum also for making this rotation flap movement easier. So this is the septum plan. And the dissection plane is also important because at the end of the surgery, we will fix the caudal portion of the septum to the anterior nasal spine. That's why I will not dissect the perichondrium at the first 1 centimeter of the septum. So I will keep intact the perichondrium on the septum here. After 1 centimeter, I will dive into cartilaginous plane, so supraperichondrial plane here, subperichondrial plane here. This is the sub, this is the supraplane. So it will be actually not easy if you are the beginner because Diving under the perichondrium is easier. It's a very easy plane. This is also easy, but it needs manipulation, it needs training. So you have to practice, like I'm going to show you. The main trick is tension. Once you create the tension on the mucosa, you can easily dissect supraperichondrially on the caudal portion of the septum. When we need to approach the dorsum, it means that we have a S-shaped bony cap here. If it's S-shaped bony cap here, we need to rasp, we need to trim the upper lateral cartilaginous shoulder, then I approach the dorsum. For this individual, we need to lower the radix height. So we need to deproject the radix. That's why I need to approach the dorsum, not for reshaping the dorsum, but changing the height of the radix. I need to approach here. So I will go between the scroll and the midline Pitangui ligament. I will show you how I'm doing. And another important point that we are going to do, the close approach incision. Because in close approach, if you want to deliver the DOMS, if you want to approach everywhere, you need a long incision. This is the preform apertura here. So my incision is ending up on the preform apertura. I will follow the rim, caudal rim of the lower lateral cartilages, and my incision will be very long till the foot plates. So this will be my close approach incision to approach everywhere. You can do extended dissection, you can do limited dissection. For this case, I don't need extended dissection. I will keep the integrity of the attachments between skin and the skeleton. So I will keep the ligaments intact, and I will approach the osteotomy tunnels through this preform apertura on this direction. Let's start. Okay, the first step for the incision. You need to put your double hook, and you need to use your middle finger to deliver the cartilage through the vestibular skin. So you can differentiate the caudal border. How? Because sometimes patients has thick skin, you cannot see the caudal border of the cartilage easily. You can use your Freer elevator to press the cartilage, squeeze between the middle finger and the instrument. Then once you come caudally, your instrument makes some fall movement at the border of the cartilage. Then when you feel this step, your cartilage caudal border appears by itself. As you can see here, now I can see my incision line. If you don't want to enter inside of the cartilage, it is the easy trick that you can use. The incision will follow the caudal border of the lateral crura, and it will end up exactly on the preform apertura. And there is an accessory cartilage here. As you can see this bump, this is the accessory cartilage. We will see also accessory 1, and we never enter the telesubcutaneous cutis. This is the lobule area, and there is no cartilage inside. So we will keep that part intact. And if you measure the pressure of your instrument from 1 to 3, the 1 is very slight pressure, this second is the medium, and the third is the hard pressure. This is the pressure 1, I can say. Very smooth movements, and we don't cut the cartilage. This is the first incision, lateral incision, and the second incision is the apex incision. Then we change the double hook position to the apex of the nostril, and we press with our middle finger, and we make the apex incision. Then the third incision is the medial incision. We just continue and follow the line, caudal border of the medial crura till the foot plates. As you can see here, from the foot plates till the preform apertura, we have a long incision in close approach for delivering the cartilages easily. Then the second movement, my assistant will put the hook to the vestibular skin, not to the cartilage. With this maneuver, we can easily see the caudal border of the cartilage. turning point of the cartilage is the most visible part because it's the thickest portion of the cartilage. Then you can easily deliver the cartilage exactly on the turning point here. Now you can see the cartilage. You can continue with your scissor, but scissor can enter easily to the CMS, which has the very bloody layer. That's why I prefer to go with the elevator, as you can see. And this is the chiral retractor. You can see the cartilage. If you see the clearly cartilage, you don't see bleeding. I always use cautery before bleeding. This is the usual way I use. There is also the later muscle attachments. We have to separate from the lateral crura. Once we continue this dissection, you can see the first accessory cartilage. This is the first accessory cartilage. This is the tail of the lateral crura. When we see the first accessory cartilage connection, this is the end of our dissection here. So we have to change the direction from lateral to vertical because we need to approach our osteotomy tunnel. This is the scroll attachments you can see here. This is the scroll. And this is the piriform apertura. Now we need to feel the bone. I feel the bone here. When I scratch the bone with my periost dissector, I will go easily under the periosteum. Here you can see the bone. And when I scratch, I feel that I am just on the bone under the periosteum. It is very easy dissection by the way. You can see the bone here. It is very easy dissection. I will show you from outside. Up to medial canthal ligament, if you're under the periosteum, you dissect the medial canthal ligament superficial branch by itself, because superficial branch of the medial canthal ligament is attaching to the periosteum. As you can see, this is my osteotomy tunnel. When I pull it up my instrument, you can see the screw. This is the nasomaxillary suture line ligament. Then I will put some cotton with adrenaline. It's not bleeding, but I want to dry operation theater field. That's why I will put the cotton now. With the rope, it's important, otherwise we can forget. Then I will continue to the dome dissection and medial crura dissection. Now we will change the direction of the hook. Again, the vestibular skin we will grab with this hook, and my assistant will pull downward like this. This is different than the open approach, the direction of the instruments and the forces we use. Okay, now I will turn over the dome. My assistant is pulling downward the vestibular skin. And as you can see, this is the patient's own dome defining point. Now my assistant will put the hook, grab the tissue, and again downward. I'm just pulling the skin up, so we are creating tension. Contraversion. Then you will see this is the medial crura. So all the lower lateral cartilage is delivered, and like in open approach, I can see all the details of the lower lateral cartilages. The scroll cartilage started to show up. As you can see, this is the scroll cartilage. It's between the lower lateral and upper lateral. Leave it free. I can show you the movement of the lower lateral cartilages. When I pull down, you can see that the scroll cartilage is delivering, and we can do arthroplasty easily through this approach. This patient is lucky because lateral crura is very flat, very straight, and we don't need a huge rotation, actually no rotation, so we will just define the tip defining points and give support. That's it. And let's start the dissection on the other side. Okay, exactly the same thing. I put my double hook, so I press the lateral crura between my elevator and the finger, middle finger, so I can easily draw the line of the caudal border of the lateral crura. Usually this line is exactly on the hair bear line, but sometimes 1 or 2 millimeter difference between. That's why it's better to draw the line and be sure your incision is in the correct point. The pressure is number 1. I'm not pressing a lot. It's superficial incision till the piriform apertura, and the second incision is immediately under the dome, vestibular apex incision, and the third incision is the medial crura incision. My assistant is again pulling the vestibular skin downward. We are creating tension. We will just find the cartilage, then we will go suprapericondyl. Most of the cases, I don't like to use subpericondyal plane dissection on the tip of the nose, because when you do subpericondyal dissection, the cartilage is becoming flimsy, so your suture tip plasty is under the risk, because you can easily tear the cartilage with your suture material. This is suprapericondyal dissection. I know that it looks like sub, but it's not subpericondyal. If you're really on the suprapericondyal plane, on the lateral crura, it's very whitish and you don't see bleeding. And of course, the local injection, weighting, everything helps same time, but the plane should be the correct plane. Again, it's not bleeding, but I will use the Bowie for just not having bleeding at the turning point, because we know the anatomy. There is a vessels just crossing this area. This is the accessory cartilage starting point. You can see the first accessory cartilage. Most of the surgeons, they don't enter this region. I know you don't need to if you are using open approach. If you are using extended approach, you don't need to see this cartilage even. But for this approach, I need to see, because I need to approach the osteotomy tunnel through this incision. This is the first accessory cartilage. This is the tail of the lateral crura. And now I approach the piriform apertura. You can see the reflection of the piriform apertura. This is the piriform apertura. It is very visible. Now I will scratch the periosteum over it. Now I scratch the periosteum with my bone elevator. Now we see the bone. This is exactly Webster triangle. Now I approach to my osteotomy tunnel. I have to change the direction of my instrument from lateral to the vertical. Then I will just follow the route of lateral bony compartment. Look at this medial canthus movement. When I force medial canthus is moving, it means that I am exactly on the correct place. I am under the periosteum. Then I created the tunnel. When I pull it up, you can see the groove. It appears because of the nasomaxillary suture line attachment. So we have to be as much as low as we can. I will put again the sponge for vasoconstruction. Then we will deliver the other dome and medial crura. We are again putting the hook, exactly the same thing like we did on the other side. We are pulling the lateral crura downward and forcing my elevator upward. Then dome is delivering by itself. This is the patient's own dome defining point. Then again, we are changing the hook position. Now my assistant is pulling up. I am forcing down. So we are delivering the medial cruras. This is the other side. In between, there is nothing actually. You can see the two domes together. Patient has very flat, nice lateral crura. We are lucky for this case to show basic steps. without difficulty. I need to approach the dorsum for this individual. Why? Because I need to lower the radix. I don't want to disarticulate the connection between the skin and the skeleton. This is the scroll attachment here, and this is the midline Pitangui attachment there. Between them, I will just create the window. I call it group 2 dissection. If there is no need to approach the radix, if there is no need to approach the dorsum, I don't do this window, I don't open this window, and I approach directly to the septum and do all my job through the septum. Now I want to show you the window I open between the midline attachment and the scroll attachment. This is the scroll cartilage, this is lateral crura. Between these two ligament attachments, I open the window. Through this window, I can easily approach the dorsum. I can rasp the bony cap. I can trim the upper lateral cartilageous shoulder if there is deformity. I can put the camouflage grafts. I can put augmentation grafts to the radix, or I can reduce the radix height, so I can deproject the radix. For this case, my main reason that I approach the dorsum is lowering the radix, so I need to deproject the radix. This is the upper lateral cartilages, and this is the connection between the bone and the upper lateral cartilages. Exactly on this level, we should not continue our dissection. We have to go deeper, so we have to be subperiosteal. And I will show you how I start my subperiosteal dissection. I start usually from the side. I feel the bone. This is the upper lateral cartilages. I just scratch the periosteum here and go under the periosteum. If you start on the midline, it is not easy. If you start from the side, it is easier. Now this is subperiosteal dissection. The reason I do subperiosteal dissection here for not having any wrinkles at the end of the surgery, because patient can get really not good wrinkles when they smile. Okay, now I feel the bone here. I just scratch the periosteum. Gösteremiyorsun. Do you see? This is the bone. I am subperiosteal here. This is on the left side, so I will continue the dissection to the midline. Then I will make connection between right and left, subperiosteally. Okay, very nice. I approach the radix. Normally, if I don't want to change anything on the radix, I don't dissect the radix area because my periosteum keeps intact everything. As you see, this is the suprapericondrial dissection plane, then subperiosteal dissection plane. Now we approach the radix. Now I will check if the procerus muscle is hypertrophic on the radix. I resect the procerus muscle. Even not hypertrophic, I like to resect some fibers of procerus muscle on the radix because procerus makes sense for projection of the radix. Now, how I approach the radix and how I approach the procerus muscle. Punch alayım çocuklar. This is the Takayashi punch. So I will approach the radix. I will grab the fibers of the procerus muscle. Then I will excise some fibers of procerus. Now I will approach the radix and I will excise pieces of muscle fibers. Because when I make the reduction on the radix area, when patient wakes up, because of the muscle contraction, it doesn't show the effect of my reduction. That's why I need to make free of this tension. That's why I will approach the radix. Through that window I open. This is my forceps. Then what I'm going to do, I will pinch the skin here and I will grab the muscle fibers on the midline. If you're on the midline, you're safe. Then I will excise the piece of muscle, as you can see here. Very small piece of muscle is excised, but you can see the effect. Now we can see the deepness of the radix. It's very visible. Now I will grab one more tissue and I will excise the piece of muscle again. Then you will see the effect, because now I grab one more tissue. Look at the radix. My radix started to show up nicely lower without any bone work. It was straight like this. Now I excised the procerus muscle here. Then I created the notch on the radix. Now it is more feminine, even without bony work. Of course, I will do some additional tricks on the framework, but the soft tissue envelope work is very important on the radix. Sometimes when I do augmentation on the radix, I still do this maneuver. Why? Because this muscle contraction can create tension on my radix grafts. Now we have the nice radix. It is very visible, without rasping, without reduction on the bone. Okay, what we are going to do, we will do the supraperitoneal dissection on the first 1 centimeter of the caudal border of the septum. So I will use the mucosal incision, hemitransfixion incision here. So my hemitransfixion incision will be very superficial, because I don't want to cut the perichondrium first. In normal septoplasty, we have got used to use subperichondrial plane, and it is easy for us to enter the subperichondrial plane. This shining layer is our perichondrium. So I will not destroy the perichondrium, but trust me, when you start first time to try supraperichondrial plane dissection, it will not be easy, because it is easier to enter the subperichondrial plane here. When we are the residents, when we are the beginner, we were always making mistake to enter this plane. We were thinking that we are in the subperichondrial plane, but our teachers were saying that, no, you are not. But now, we are trying to keep on this plane on purpose, because I want to fix my septum to the internasal spine strongly. So the trick is creating tension. As you see, when I pull the mucosa laterally, and my assistant is pulling the columella medially, we are creating tension, and it is becoming easy to keep going on the supraperichondrial plane. This is the supraperichondrial plane. It is a shining layer, as you can see. I'm just forcing a little with these attachments. So supraperichondrial plane dissection is appearing. Why I'm doing this? For just making the connection stronger at the end of the surgery, because I will fix my caudal portion of the septum to the internasal spine. Then I want it very strong connection there, because that stitch at the end of the surgery will keep the position of the dorsum, position of the nose. So it is very important. Exactly same thing I will do on the other side. I'm just using my scissor for this section, but I'm not entering the subperichondrial plane here. I will create again tension. As you can see, I'm just following the fibers, pressing to the cartilage. Keep going on the supraperichondrial plane. Now what I'm going to do, I will just scratch the perichondrium very superficially. I will not cut the cartilage. You can see this line that I scratch. Now this is the subperichondrial plane. You can see the perichondrium. This is the borderline between the supra and the subperichondrial plane dissection. In first 1 centimeter, I kept the supraperichondrial plane. Now this is the borderline between the sub and supra. Now we will just scratch the cartilage like this. Not cartilage, actually perichondrium. You can see the incision here. This is the perichondrium. This is the borderline, supra and subperichondrial plane. Very visible. Very nice. Then I will go ahead till the perpendicular plate. In this part, better to put some elevator. Biraz dışarı çıkacaktım. Now we have to see the connection between the ethmoid bone and the quadrangular cartilage. Also, we have to approach the base, and we have to disarticulate the quadrangular cartilage totally from the base and the ethmoid bone. Okay, this is the base. Here is the connection between the ethmoid bone. You can see the bone and the cartilage connection. I will split that connection, and I will make the cartilage free of the bone. This is the caudal portion of the septum. And once we enter, we can see the first 1 centimeter supraperichondrial dissection. Then this is the borderline of subperichondrial dissection and supraperichondrial dissection. Then once we keep going, we will find the ethmoid bone connection here. This is the ethmoid bone connection. Then we can see everything under direct vision. This is the inferior tunnel I created on the base. Now I will disarticulate the septum from the maxillary bone and then ethmoid bone. This is the base of the first 1 centimeter of the caudal portion. And now we will disarticulate the base from the internasal spine. Okay. Now we are disarticulating the caudal portion from the internasal spine. This is the internasal spine connection. Now this is the disarticulation from the internasal spine. Septal cartilage is very thick on the base. Okay, now you can see the groove on the maxillary bone. I think it's very clear. I disarticulated the septal cartilage from the base. Now the same thing from the ethmoid bone connection. Ethmoid bone connection is easier because it's not the strong connection. This is the ethmoid bone here. Vomer on the base, perpendicular plate. So we disarticulated the quadrangular cartilage from the base and the ethmoid bone. Now it is free of tension bone around. When we turn our camera upside down, we can see the roof. It's splitted from down to up. And I will disarticulate a little bit from the upper lateral cartilages for making my rotation easier. Now what we did, we separate this connection, we separate ethmoid bone connection, and we separate the maxillary bone connection. Now I will approach the ethmoid bone immediately under the hump, and I will cut with my long piezo insert. It is very easy to make this cut because once you push the pedal this way, it will just make a 1 millimeter cut. If you want a little bit more, you can make 1 millimeter cut. The reason I use piezo, I don't want to harm the bone. I don't want to create unwanted fractures. I don't want to grab the bone and tilt, because you can use baby ronger for the cartilaginous part. If there is cartilage here, you can use baby ronger. This baby ronger is very helpful. You can go and grab. But if you grab the bone and if you tilt a little bit, you can create unwanted fracture lines on the perpendicular plate, which can be risky. And another reason, if you don't want to change anything on the radix, if you're keeping the projection intact, it is better not to excise immediately under the radix osteotomy line. So I will just make a cut here and radix will not drop down. But for this particular case, maybe I will resect a little bit more to create some step on that region. Maybe not, because after the process injection, I've got already radix deepness. Okay, now endoscopic view is very good. This is the highest portion of the ethmoid bone. When I put my foot on the onto the pedal, now you can see the cut. It is very precise because once you cut, it's just 1 millimeter excision and 1 more millimeter excision. I'm just creating the gap. As much as you need, you can continue to this dissection. As you can see, I create the gap with my piezo insert. Now I will resect this portion. Seems like it's a little bit cartilaginous, so baby ronger can help. This is the end point of my cut. I put my finger. This finger is my measurement. I go out, put again. So I see that I'm exactly on the radix area, so I don't need to go forward. The main idea is making connection between this ethmoid bone cut and the radix osteotomy line. So it's deep enough. Very nice. This is the ethmoid bone. And this is the wedge I created, as you see, like triangle shape. You can see the connection on the dorsum. Now, looks ready. The next step is the lateral osteotomies. I want to draw how I'm going to approach the lateral osteotomies and what I'm going to do there. We approach the lateral osteotomy tunnel through this lateral bony compartment. So this is the preform of apertura. And this is the nasomaxillary suture line attachment. I will excise a piece of Webster triangle here because immediately under this triangle there is a inferior turbinates bony fragment. It can overlap and it blocks my movement. That's why I will resect this piece first. Then I will go till the medial canthal ligament region sagittally. So I will create some sliding surfaces here. Then I will change the direction of my instrument and I will go sagittally again and I will complete halfway my transverse osteotomy. And then I will go with the radix osteotomy and complete this part. So the nose pyramid will be completely separated from the face. If we draw sagittal plane, my osteotomy will be this way, sagittal way. So it will drop down the dorsum easily. If the nose is tilted, like today, I will make sagittal on the longer side, which I want to tilt the nose to the right, and I will make little more oblique here to block the movement and let the nose go to the midline. If there is no hump, I can easily make horizontal osteotomy here. It blocks the movement totally. But now there is a hump, that's why I will make a little bit more oblique here, more sagittal on the right side. I have a special retractor for this reason. It's my design because I need to create the osteotomy through the tunnel. I don't want to destroy the ligament connections. Let's start with the Webster triangle excision. The position of the instrumentation is very important. My nurse is pulling medially the lateral crura, this direction. My assistant is pulling the ala laterally, pulling the lateral crura medially, and I'm putting my retractor. So this is the fascial groove where the nose starts to rise up. So frontal process of the maxilla. So I will make the cut and I will excise the piece of Webster triangle for not overlapping with the inferior turbinates bony fragment. This long piezo insert works wonderful for every reason on this approach. You can see the cut, it's very precise and fast actually. This is the second cut. I will excise the triangle shaped bone. In structural rhinoplasty, we don't excise, we keep it intact on purpose, not to blocking the airway, but this is totally different philosophy. We are trying not to impact the, not to overlapping the bones and not to block the airway with additional volume of the inferior turbinate. So this is the Webster triangle excision. Let me show you what happened inside. Now you can see the defect here after this excision. Then I will change the direction of my insert because I was cutting horizontally. Now I will change sagittal direction like this because I want to drop down all the pyramid, so it will impact inside of the maxillary bone. This special suction retractor is amazing because otherwise you cannot use piezo device nicely here. And this tunnel is more than enough to see under direct vision. As you can see, I excise the Webster. Now I'm cutting sagittally the bone. Okay, it's time to change the direction because of the transverse osteotomy. Now I will change the direction of my insert, and my assistant is changing the direction of the retractor this way. I don't want to touch the retractor. It is very important to create some sagittal cut also at the corner. Otherwise, you cannot impact the pyramid nicely. It is done. Now we can see the movement of the bone. You can see. And the second step, we need to release the periosteum inside of the maxillary bone because we will impact and we need the gap. And the third, we will do ballerina maneuver. Ballerina maneuver is basically this articulation on the lateral keystone. The first, on the longitudinal piriform ligament here, I disarticulate. And the second, upper part, is a little stronger because the upper lateral cartilages are attaching to the nasal bones. Then we need the blade. We need to trim a little bit the piriform ligament here, vertical piriform ligament. Otherwise, we cannot create the movement nicely. And now our 15 blade should not be perpendicular to the cartilage, otherwise we can cut the cartilage. Our 15 blade should be parallel to the surface of the bone. So this is the ballerina maneuver. This articulation of the lateral keystone. So as you can see, this is the upper lateral cartilages. This is the nasal bones. So I basically disarticulated them. I put the freer elevator, and my freer elevator is my guide now. I will put my finger and I will feel my freer elevator on the dorsum. So it should come up to dorsal aesthetic lines. If you want total release, it should come till the dorsal aesthetic lines. Now it's done. Okay, this is the lateral keystone. Now you see the disarticulation on the sidewall. Yes. And this is the upper lateral cartilage connection. Till the dorsal aesthetic lines, we release the lateral wall connection. Okay, nice. I will resect a piece of Webster, not a big piece, enough. What does it mean enough? Not to overlap with the inferior turbinate. Okay, smaller piece on this side because I want to tilt the nose to the right side. I don't need a big gap. But anyway, we have a gap, 3 millimeter. Why? Because piezo insert is 1 millimeter. So it excises 1 millimeter by itself. I excise 1 millimeter bone and 1 millimeter on the lower side incision, so 3 millimeters. Okay, now this is the Webster triangle excision. And this is the sagittal cut. Now we are turning the direction for the transverse osteotomy here. This is the transverse part, turning up. I can show on the other side actually, this similar. This is the Webster triangle excision. Then this is the sagittal cut till the medial canthal ligament. When it moves, do you see it is moving? It means that it's disarticulated. Now I will complete a little bit more the transverse on the left side. Now I'm completing the transverse. Now we will go with the ballerina maneuver again on this side. This is the ballerina maneuver. Till the upper lateral cartilages, it goes so fast and easy because this is the longitudinal preformed ligament attachment. Then we need to cut the preformed ligament because it's very strong connection in between. Then we need to disarticulate the upper lateral cartilages from the nasal bones. 15 blade is making our job easier. This is the bone. Just be parallel to the surface of the bone. You don't need to be afraid. If you are parallel, you cannot harm the cartilage. As you see, it's just the disarticulation between the upper laterals and the nasal bones. Çok sallıyorsun dedim. Yes, this is the disarticulation of the side wall. We call it ballerina maneuver. Now you can see the disarticulation on the side wall, very clear. I will put my freer elevator and I will be sure that it's totally disarticulated. Then I will put my finger on the dorsum outside and I will feel the movement of my elevator. When I feel it, it means that I came to the last dissection point. It means that my dorsal aesthetic lines are already there, so I should not go forward. Now, it's already done. We did nicely low-to-low osteotomies. We completed our sagittal osteotomies, resected the Webster. We made the halfway transverse osteotomies. Then I need to release the inside of the maxillary bone periosteum here because it's another blocking point, so I don't want to struggle. I just want to create the gap with my piezo because there is an inferior turbinates bony fragment. When I feel that it is very strong and superficial, I like to cut with my piezo because I need space for impaction. Now I'm just making cut to the inferior turbinates bony fragment. I will check on the other side, is it the same? Because sometimes this layer can be blocking point, even if you resect the Webster. I'm just going back and forward with my insert, piezo insert, for just being sure if there is any blockage or not. Okay, most of the time, if I'm dealing with the crooked nose, imagine that this is the nose and this is crooked to the left side. We have the connection with the intranasal spine like this. And this piece is not on the midline most of the time. Our mouth is here and midline is little bit on the another side of the intranasal spine here. So what I do most of the cases, if I use low septal strip, I make a surface here, a little bit trim the intranasal spine, so I overlap this part of the septum with this part of the intranasal spine. So my connection is usually like this. For making the septum straight, I made this kind of trick. So my intranasal spine trim a little bit, and I go forward till the maxillary crest, and I make a straight line. And I overlap this piece with the intranasal spine. This is very important detail. Why? Because if you overlap with the intranasal spine, your intranasal spine is losing the height. Imagine that I made this surface 3 mm deep. It means that I will lose 3 mm height from the septum. So you don't need to resect at the beginning. So when we reduce the height 3 mm, we have to measure how much millimeter we need more. Maybe we don't need at all. That's why I don't trim the lower portion of the septum. I don't do the low septal strip at the beginning of the surgery. I keep it till the end intact. Then I will decide at the end how much resection I will need. Now, I will check the intranasal spine. Our midline of the teeth is here, and our midline of the lip is here. And our intranasal spine is on the little bit left side, as I guess, because That's the reason that this nose crooked. So what I'm going to do, I will trim a little bit right side of the internasal spine here with my piezo, and I will create the wedge to put my connection on the right side of the internasal spine. How much resection I do here, it is very important. That much I don't need to cut and excise from the septum. Okay, super. So we have a flat surface. This flat surface concept is very important. If you don't create this flat surface, the caudal portion of the septum can tilt to the right or left. That's why I'm trying to make it flat. Very nicely. Yeşilliğini alayım çocuklar. Now I will make a hole to the internasal spine for better fixation. I'm just preparing on this part of surgery, on this step of surgery. As you can see, I just put the needle and making right, left movements. One hole is ready. Let's make the second hole as a guarantee. If I'm fixing side to side, just 2 holes is more than enough because I don't need to fix with the grooves, I mean the shoulders of the notches. But if I'm fixing on the top of the internasal spine, usually I create the groove and I create 3 holes for making the stabilization better. Okay, let's check the septum. Usually the base of the septum is very thick, so we need to trim a little bit for not making thickness. Do you see how the base of the septum is thick? So we need to trim a little bit, and we need to make some connection this way. I will trim. Super. Okay, let's go with the radix osteotomy. Everything is prepared. Then we will decide how much resection we will need. Your osteotome should be very sharp because I will use the osteotome through the skin. Each time when I use this osteotome, each time I rasp, I make it sharp. So it is very important. Then when it comes to radix osteotomy, it depends on what you need, what you want. The radix osteotomy level should be the lowest portion of the radix. In this case, I want to lower a little bit radix, but I did it already just with the muscle excision. That's why I don't want to drop down too much. I will enter a little bit higher to put my osteotome parallel to the osteotomy lines because I want to create hinge there. When my assistant make tap tap, medium tap tap. First, I will cut the middle portion. Okay, then the same entrance hole, I will change the direction to the right, and I will complete my prepared transverse osteotomy. Tap, tap. Tap, tap. You have to feel that there is movement. And another side to the left. There is a common question why I'm not using piezo here, because piezo is a very nice instrument to work on the bone. I'm not using piezo because I want to create breaking line here. I want to create some hinge here. It is the main reason that I don't use piezo. Now, my pyramid started to move right and left. You can see the movement. The nose is separated from the face. Now I can tilt my nose to the right, to the left, wherever I want. I want to tilt to the right. So when I press, it will go down because there is no support anymore underneath. And the rotation flap, when I move the rotation flap, it will change the shape of the dorsum. This is my septum, caudal portion of the septum. Okay, when I change, as you see, when I push, it goes little down. Of course, I didn't resect the septum yet, that's why it cannot go anywhere. There is no space. But even without that space, dorsum looks better. Now I will create the space. I will resect a piece of cartilage from the base. Then we will see the movement, how hump goes down. Okay, let's excise. I highly recommend to excise the low septal strip incrementally, step by step. If you excise too much, it is not easy to turn back. It's an irreversible maneuver. That's why I will excise incrementally. Now you can see the excessive portion. Maybe sterling. Endoscope can help us to see better. And another important rule, don't excise too much from the caudal portion. You can excise from the posterior portion. Very small, almost 2 millimeters from the caudal border. Little bit thicker on the posterior side. So this is the piece I remove. As you see, posterior side I don't care because this will be my height for supratip area. This was the septum I resected. I resected very small amount, 2 millimeters on the caudal border, but on the posterior side I need a graft material maybe, and this piece, very nice piece for using as a graft material. I can harvest more if I need graft material, but this is more than enough now. And after this resection, I have a gap. This was before we had hump, and when I rotate the flap, hump is gone. So if I don't need to reach the radix like the procerus excision, like this case, I don't need to approach the dorsum at all, because I don't need to do anything there. As you see, this is the rotation flap, this is the hump before, and then with this stretching, hump is gone. Then when we do tipplasty, we will see the nice shape of the nose. And another important thing, for example, now I left the position of the cartilage like it is on the table, and it should not jump up. There should not be resistance. If this hump is jumping up on the table, and if you need to push always with your finger, it means that there is a resistant point. So you have to turn back to your blocking points and you have to deal with that blocking points. Now it's very stable because we killed all the tension. I need a little bit more gap on the right side of the intranasal spine and the maxillary crest. Yeah, the tunnel I created is here. You can see this is a flat surface which I draw with my piezo insert nicely from the intranasal spine. Do you see this groove I created with my piezoton? And my septum will sit on this groove, and I will fix it with 4O PDS. This is the intranasal spine. On the left side was located, so I created the groove on the right side. And this 3 millimeter gap is already kind of resected part from my septum because it will overlap. The cartilage, quadrangular cartilage, which I disarticulated, is there. This is the ethmoid bone. And this is my supraperichondrial dissection line. And the cartilage in between, like triangle shape, I can harvest because it's not my support. So I can still harvest a huge piece of cartilage, as you see here. This is the cartilage I harvested on the middle of the septum because this is not my support part. My support is still on the caudal portion. And this was the subperichondrial dissected cartilage. I can use as an extension graft, I can use as a columellar strut. And if I need grafting on the tip of the nose, I can use this cartilage easily. So this will be my grafting material. And then I will check again the height of the septum. Is it good enough or not? I'm putting to the midline. I'm not forcing, I'm not stretching the cartilage. I just see if the height is good. A little bit more dissection and resection can be helpful. I feel it. Just 1 more millimeter. Then we will see, is it enough or not. Not too much. If you resect too much, you cannot put it back easily on the place. Then you need to revise. Now, as you see, this position is stable. It's not jumping up. I don't need even putting suture, but of course, for security reason, I need to put the stitch. Now I can show you the flap movement. It looks nice from the side. This is my flap. This was the hump before. Then it's gone. Hump before, it's gone. So when I put this cartilage on the place, it stays. So what I did before, I create the hole with the needle. Now you can see my needle pass through that hole. Okay, this is for PDS. I pass from left to the right. Now I will pass through the caudal portion of the septum. The reason I use supraperichondrial dissection is this, because this stitch should be stable. If you don't keep the perichondrium on the cartilage, you can easily tear the cartilage. It's like cheese wire. Then you can end up with some complications. That's why it is very important for me to use this supraperichondrial dissection on this part of the surgery. Now I will cross the soft tissue on the intranasal spine like this. This is the side-to-side connection. When I do low septal strip, this is the most common connection between the intranasal spine and the septum in my hand, because most of the time, if I'm using low septal strip, it means that this connection is not on the midline. It means that I need to make straightening the nose. Check the nose. So at least 5 knots I put for monofilament stitches, sometimes more, but my hand memory makes usually 8. Okay, let's see what happened after this fixation. We have very flat, nice dorsum, no hump anymore. Radix height is very good, thanks to procerus excision. We don't need to rest the radix. Now dorsum job is finished, by the way. And she doesn't need a huge job on the tip of the nose. We just need to give some support to the tip. So I will use a small trick to use the ligament's power here. Then I will just make small extension grafts. Then I will hang the ligaments over it. So it will be okay, because the tip of the nose doesn't look bad. I will just define the tip defining points, and I will check the both sides. On this part of the surgery, I change my position to the head of the patient. So I look to the tip from the top, because I want to see and measure the tip's if they are equal or not. I don't want to make any mistake. So this is her own tip defining point. Actually, it looks not bad, it looks good. She doesn't need rotation from the beginning. I decided not to make rotation for this nose. I'm just marking her own dome defining point. So I will do exactly the same thing on the other side. I'm just holding the tips, pulling them, creating the tension. Marker, please. Patience, own defining points. I marked. So these are the patience on the dome defining points. I will not change them. And lateral curas are already flat, so I don't want to change the shape for this individual. Just for little definition, we can trim a little bit this cephalic portion, and it makes my tipoplasty easier. Not too much, very slight. Yok, yapmayacağız bunu. Subperichondral dissection I applied because I don't want to destroy the scroll. So it is easy. If you are subperichondrially, because scroll ligament is attaching to the perichondrium, if you are subperichondrially, you cannot destroy the scroll. That's why I did the subperichondrial dissection here. On the other side, I will do the same. Very small trim on the cephalic border, just for the definition on the scroll. Okay, I will again try to go subperichondrially. Okay, nice. Now I will make definition on the tip of the nose. As I told you, she doesn't need a big change. She just needs little bit definition. 5-0 PDS. Now my nurse is pushing up the dome defining point. If you steal from the lateral, she would push exactly on that line, but now this is her own dome defining point, so she is a little bit pushing up. The first stitch I use is the matrix stitch oblique version on the lateral side, from medial to lateral, then not horizontal, not vertical, not here, not here, oblique, like this, the second stitch entrance, then medial side. When I squeeze, as you can see, it little bit made narrow the cephalic portion of the knee dome. The second stitch is little lower than the first one. It's a Gruber stitch, hemidomal stitch. This helps to elevate the caudal border of the medial crura. It's not such tight, little loose, but gives the shape. If the nose is droopy, if the lateral cruras are long, I prefer to use lateral cruras steel and combine with the stitches. Now I will repeat exactly the same thing on the other side. My assistant is pushing the dome upward this way, and my entrance point is from medial to the lateral. Then from lateral to medial oblique version, I will press again. Yes. This is 5/0 PDS, and the second stitch will be again Gruber stitch, the corner. The second stitch is little lower than the first one. From inside out, hemidomal stitch. Once we squeeze this, it will help to rise up the border of the caudal lateral border of the lateral crura. Okay, can you cut please? Now the next step, we will put two domes together on the midline. They were together at the beginning, now they will be again together. If you need rotation, you can trim the soft tissue envelope and you can create the packet a little bit higher position. But now we don't need rotation, so that's why I don't want to create a new packet. The rotation will be the same. Again, my assistant is putting the hook and pulling upward my left dome. If you're left-handed surgeon, it can be opposite. And now, what I'm going to do, I will put two domes together from the cephalic edges. So I will cross from in to out on the right side. Then I will do exactly the same, but from opposite direction on the left side. So this is in to out, and this is out in. You can put figure 8 suture. I like this kind of single stitch. Now I put the two domes together on the midline. As you can see the domes under direct vision together, like open approach. It's not a big deal. So it depends on the type of the cartilage. If they are strong, you can use columnar strut. If the cartilages are weak, and if you need support, you can use extension graft. Okay. Okay, very nice. Actually, the position of the tip is very good. But because of the tip stitches, I feel a little depression, because at the beginning the tip was good. When we squeeze, we create the notch here. So it means that just putting the two domes together can help for this individual. It's very rare that I don't do tipplasty, but for this case, I think without tipplasty, the result will be better. Then I will check, I will take out the stitches. And anyway, I showed how I'm dealing with the tips, with the stitch tipplasty. Now I will see, without that tip stitches, how it will be looking. First, I took out this Gruber stitches on the both sides. Let's see what will happen. Yes, now we see better. That notches are a little bit better now. Okay. And the first stitch I put, the oblique one, I will remove, and we will see the effect. Because normally when we combine the stitches with lateral steel, we are creating the knee dome and we are creating the knee arch. Look. when you don't do any tipplasty, the nose looks better. Because her tip was already so good. You look, do you see? Just we need support. Then I will put support. So, it's so weak. This kind of flimsy cartilages, I prefer to put columellar strut, very thick one, or extension graft. And I think extension graft is easy. We have material, so I will put one extension graft and I will give the support to the tip. Then I will show you how I'm using that extension graft. It is also tricky way. I'm just making the cartilage surface flat, trimming the white part of the cartilage. Now, as you remember, I didn't cut anything between the medial crurus, the interdomal ligament, intercrural ligaments. They are all intact. And there is a nice layer which I can use as a support on the soft tissue envelope. It is very important because soft tissue envelope is attached to the perichondrium. If you don't destroy the connections, you can really use them as a support, because there is no suture can be more powerful than the ligament connections. We resected this part for grafting, and we put the fixation to the internasal spine here. So we have this kind of caudal portion of the septum. Now I will put my graft like this. It's kind of extension graft, but modified. If you put the graft half and half, it can bend, it can turn to the right or left. If you put your graft a little bit longer, like 2/3 here, 1/3 extension, it cannot move anywhere. So it is very important. 2/3 of the graft should be overlapping, 1/3 of the graft should be extension. So I will put my graft on the right side of the caudal part of the septum, because my caudal portion of the septum was tilting on the left side. It was appearing on the left side. So this is my graft material. Now I will check which position will be good. And it should not be so thick, because if you put very thick, it blocks the valve, so it blocks the airway. That's why it should be thin, but it should be supportive enough. Okay, let's go to the table. At the beginning, there was a deformity. On the left nostril, we were able to see the septum, so it was not symmetrical. Now, we see the symmetrical nostrils. That's why all the position and anatomy changed. That's why I will check again to put this graft to the right or left. But anyway, right has a little bit concavity. That's why I prefer to put to the right side of the caudal portion of the septum. Yes, it will be like this. As you understand, overlapping is very short. Overlapping is very long, and extension part is very short. So it's very stable graft. If you don't put this way, it can turn right or left. Okay. Now I will fix with 5/0 PDS. If you are on the supraperichondrial plane, you don't need to use any permanent stitches like Prolane. I don't like to use Prolane in the nose. Very rare. If I'm doing some reconstruction, sometimes I use, but very rare. So this is PDS. It is more than enough because I'm on the supraperichondrial plane. So what's the difference between supraperichondrial plane and subperichondrial plane? On the supraperichondrial plane, there are fibroblasts, and it creates fibrous tissue. So that fibrous tissue
creates stability. But if you're in the subperichondrial plane, there are no fibroblasts, so it cannot create fibrosis. So that's why you need permanent stitches. Now I'm fixing this graft on the supraperichondrial dissected area, so there will be fibroblastic activity. So it will make my connection stable. This is very old extension graft technique actually. I think the first article was published in 1990s by Italian author Beard, and also in Roland Daniels' book in 2002. It was clearly showing the extension graft. So kind of extension graft modification. Now I will put 3 more stitches to the back side for making it stable. Also, this extension graft gives support to the caudal portion of the septum additionally, because the caudal portion of the septum is this main structure, carries everything on this technique. It's very important to give the support to caudal portion. Some patients has very weak septal cartilages, so giving additional support is very important point. This patient has strong enough septal cartilage, by the way, but anyway, I'm sure that with this grafting it will be better. And also I want to thank to my nurses. They are so helpful and talented. Hale and Figen, we are always operating together and they are amazing. Thank you guys. Seems like it's very strong enough. Okay, this is very important step. We have to deliver this graft between the medial crus. So it is tricky because between the medial crus there is a interdermal ligament, and continuity of the interdermal ligament we have the connection of the midline ligaments to the cephalic border of the medial crura. So now I need the hook. When I deliver this ligament, when I create the window on this ligament area, so this is the interdermal ligament here. It's the real ligament. Histologically, it's a ligament, real ligament. So I should be under the ligament here because this ligament will carry everything. So I'm creating the window just under this ligament on chicken, and I will connect this tunnel till the septum. Then I will deliver this cartilage through that window. This ligament will carry the dome very strongly. It's like extension graft fixation, but mobile. Now I have support on the tip, and it will be looking very nice. Okay, now you can see the tip support. It is very supportive. Just with that single small graft, I will fix that graft position, but it will not be frozen tip. The tip is mobile. I can move this tip, so patient can kiss, hold, so there is no additional freezing on the tip of the nose. I will just put one single stitch, then operation will finish. I got the result, so I don't need to add additional maneuvers. Okay, I want to mark the level of fixation on the medial crura and also on the graft. I'm not pulling up because I don't want to change the height of the dorsum tip now. I'm just marking. So this marking shows me the level of fixation. Then on the other side, I will do exactly the same. Now we can see the cartilage here, which is my graft, and I will just pass through the medial crura. Then again, okay. This is the right side fixation. I will do exactly the same on the other side. Level is marked. You can see the graft. The advantage of the technique is keeping the connections and using them as a support. It's a very natural way to give tip support instead of putting the stitches cartilage to cartilage. This is easier and actually more anatomical. Okay. At the beginning, when I was talking about the case, I was mentioning the tension on the basolabial angle, which is still there. This can be because of the hypertrophic intranasal spine. This can be because of the hypertrophic muscle. So I will first exercise the soft tissue there for redraping better, because I feel that there is tension here. So most of the time it can be because of the bone, then we can rest the bone. Let's see the intranasal spine if there's something to reduce. Actually, intranasal spine is good. Okay, soft tissue resection is better option for this case. I see this tension here. Now we can see from the opposite direction my extension graft here. This is my caudal portion of the septum, and I will excise a little bit soft tissue here for not making that tension. This is actually the midline ligament and the depressor muscle area. It attached to the orbicularis oris, and it blocks the movement of the nose downward. If there is a plunging tip, most of the time we excise this muscle also. This is another reason I am doing this excision, is tension. If you excise a piece of soft tissue here, you can create nice sharp angle between lip and the nose. So this is the excision of the tissue. Bırak canım. Now this angle looks more defined. Okay, we have less tension, nose looks good, and the tip is supportive. Now the last step of the surgery, we have to put our camera to the base of the nose. The first thing what I look on this view is the nostril apex position. So the right side and the left side nostril apex should be on the same level. So now I see on the screen that they are on the same level. It is very good. And the foot plates were tilted at the beginning. You can see on the right nostril a little fold. It's just the excessive part of the mucosa. It's not the big problem. Then I will put the stitches now. But if there is a problem on the nostril apex, I have to put my skin flap little bit tilt to higher position. But now the nostril apex position is good. This is just the excessive portion of the skin here, because there is less dissection on this part. I will just put the silicones and we can put additional stitch. Septum dikişini rica edeyim. Now I will fix the septum with quilting sutures. It is also important for me not to have any hematoma from one side to another, and I will continue on the base of the septum to the posterior side like this, and then I will go up and turn to the starting point. This is the 4-0 rapid vicryl I use for the septum suture. Now I will check again the base. Okay, now it looks better, the symmetrical. Just on the left side here, I see a little bit depression just because of not putting the suture yet. As you see, my incision is still there, open. Now I will put the stitch, 6-0 rapid vicryl. After fixation of this incision, it will give support again to the... Okay. Yes, just. Now it looks better. Left and right is more symmetrical. I will put the stitches to the right side. As you see, the flap is still free here. Yes, canım. Değil mi? Tabii kör gibi oluyorsun. I don't like to put the full size doil splints because it's too high. Then I trim the doil splints a little bit from the top. Crema. And I like to cut the posterior side of the splints for not forcing my osteotomy lines. So the anterior side is intact, the posterior side is trimmed. Then my assistant will put the ointment. Then the next step, I will put the drains. The drains are basically cannulas. So this is the orange one, thick one. I will show you how to prepare the drains. I just take out the one layer of the cannula this way, and I will cut the excessive portion like this. This will be my stopper, this part, and the remnant part will be like U-shaped drain. I will show you how I apply. Through the vestibular skin, I just enter to the dissected compartment, lateral bony compartment. I am just over the bone. I feel the bone. I insert my cannula and take out the needle. And the same thing on the other side. I will apply the cannula through the vestibular skin on the posterior bony compartment, which is the dissected one. I'm just on the bone, feeling the bone. Then the reason that I put these drains, when the patient is waking up, the blood pressure will rise up. And there will be some blood collection on the osteotomy lines. Instead of keeping that blood under the skin and having bruising, I like to discharge it because the blood pressure will go up and patient will be bleeding. That's why I like to put these drains. And now the last step, what I'm going to do, I will change the lightening in operation theater to see better the contours if I need to put any additional camouflage grafting or not, because I have some material, I can dice the cartilage and I can put back to the dorsum with some needles or some injectors. Okay, now we can see the dorsal aesthetic lines better. We can compare right and left. Because of lightening, we change the lightening, and we can see the nose is straight on the face, on the midline of the eyebrows, on the midline of the lip here. So it looks very nice. So we can see the right and left three-quarter view, very nice, very stable. And we have a nice projection and very mobile tip. And all the ligament connections are intact. Even we approach to the radix and change the radix height. It looks very, very nice. Okay, now I will apply the silicones. I will fix the silicones, then finish the surgery. This is the 40 Prolane. I keep the silicones 1 week after the surgery, 7 days. First 3 days they feel some pressure, but after the 3 days they very nicely tolerate the silicones. And actually it heals so nice with silicone. That's why I prefer to put silicones. I know that some surgeon friends, they don't like to put silicones. They say that just quilting suture is enough. And additionally to the nostril apex, I don't want any snechia, and I don't want any creating sac there. That's why I put Surgicel, very small amount Surgicel, just filling the nostril apex, vestibule. So it melts, it absorbs by itself, so I don't need to do anything else there. So this is kind of protection. Let's put the cast. Okay, the first tape I put to the supratip breakpoint. The second on the dorsum continuously, one by one. Some patients has very non-elastic skin cannot redrape nicely, and then once you rotate the nose with the tape, you can create some notch exactly on the soft tissue triangle here. So for protection, to have some groove there on the skin, some breaking line on the skin, I like to put some additional tapes. It protects to create some deepness. Then we will put 2 more tapes on the right and the left side. Then I will squeeze these tapes on the midline. Then 1 more tape for the rotation and not having swelling on the tip of the nose. Okay. Kalıba alayım çocuklar. So under the eyes I always put 2 more tapes. In case if I have bruising, I don't want that bruising long term, so hemosiderin pigment can give reaction with the daylight. That's why I protect under the eyes with additional tapes. Most of the cases I don't see a big bruising, maybe a little swelling, because of less traumatic surgery, because of piezo, because of keeping the ligaments intact, because of putting drains. And this is the thermal splint. When I put this thermal splint, we just drop a little bit cold water. Çok az dök. Cold water makes the thermal splint easily form. Tamam. We always keep the ears not to get water, because when the patient is waking up, that cold water can irritate them. Then I will put 1 more layer additionally. It makes the camouflage of my cast. Patient cannot see my fingerprints, because 1 week that fingerprints can disturb them. It can create some effect like it doesn't look straight. And also, it's fancy. They choose their own color. I like to put some colorful splints on the top of everything. So this is the 1 week fun for the patient. Thank you guys. Haydi kaç yılın hikayesi dedin sen bana?
Hocam çok yılın hikayesi. Çok duyguluyum ben şu an.
Hadi
Ama
bakalım,
iyi ki siz.
hadi bakalım aynaya bak
İyi ki
bakalım ne
siz.
çıkacak altından. Şu tombiş burnu bir gör.
Aa, inanamıyorum. Hocam inanamıyorum.
Yüzünün burnu oldu. Bir patatesliği geçsin.
Hocam. Çok güzel yapmışsınız burasını.
Evet, malzeme senden canım.
Hocam çok güzel olmuş orası.
Geçmiş olsun.
Alçının arkasından şiş gibi geliyordu ama çok güzel
Şiş tabii
olmuş.
Şiş hala şiş olmaz olur mu?
Çok teşekkür ederim.
Güle güle.
Yani her şeyine o kadar okuyayım ki elinize sağlık hocam. Bütün
Oldu.
süreç için çok teşekkür ederim.
Hemen fotoğraflarını çekelim. Bir elimizde
Çok teşekkürler.
alma